Hello everyone. Today in this video I will tell you the details of cranial nerve 8th to 12th. I have already uploaded the first two part and the first 7 cranial nerve of the cranial nerve examination. So 8th cranial nerve is the vestibulocochlear nerve. There are two divisions, vestibular and the cochlear. So cochlear division is for hearing and the vestibular division is for equilibrium and the coordination. For assessment of the cochlear division, we have to assess the hearing. Both the ears should be examined separately. So the non-tested ear should be occluded by the tragal pressure. We have to stand behind the child at the distance of 6 cm. Then we have to whisper a sound. If child is turning the face toward the sound, that means child is hearing our sound. Then we have to increase the distance between ourselves and the child. If child is able to hear the whispered sound even at the distance of 15 cm, that means child is able to hear the 35 decibel. At the distance of 15 cm, some conventional sounds should be produced. Example, we can clap or we can say the name of the child, or we can play the music, or we can ring the bell. If child is turning the face toward the sound, that means child is having the 50 to 60 decibel hearing. If the child is having hearing loss, then we have to perform the tunic fork test, and for these tests we use the 512 Hz tunic fork. In this we perform the Rinne's test, Weber test and absolute bone conduction test. So for all these tunic fork tests, first we will explain to the child. Then we will charge the tunic fork on hard surface. So in this video you can see I have charged the tunic fork on my elbow. Then we will keep the vibrating tunic fork in front of the external auditory meatus, at least 1 to 2 cm far from the external auditory meatus for the air conduction. And then we have to tell the child, once the child will stop hearing, child should tell us. Then we will keep the tunic fork on the mastoid process to check the bone conduction. Normally air conduction is better than bone conduction, label as a Rinne's positive. If the child is having conductive hearing loss, then bone conduction is better than air conduction, label as a Rinne's negative. In sensory neural hearing loss, both air conduction and bone conduction will be affected, but the air conduction will be better than bone conduction, so we will label as a Rinne's positive. Then we have to perform the Weber test. We will explain to the child first, then we will keep the vibrating tunic fork over the central part of the skull bone. So we can keep over the vertex or forehead or over the roof of nose, even on the incisor teeth or chin. We will explain to the child should compare the loudness of sound in both ears. Normally sound will be equally heard in both the ear. If sound is lateralized, that means child is having hearing loss. In conductive hearing loss, sound will be better heard in the affected or worse ear. While in the sensory neural hearing loss, sound will be better heard in the normal ear. So sound is lateralized to the normal ear. After that we have to perform the absolute bone conduction test, in which we will compare the bone conduction of the child with our own bone conduction. First, close the external auditory canal of the child by the tragal pressure, and then keep the vibrating tunic fork over the mastoid process of the child. When the child stop hearing, then we have to keep the tunic fork over our own mastoid process after closing the external auditory canal. Normally and in conductive hearing loss, examiner will not hear any sound. But if the child is having sensory neural hearing loss, in this case examiner will be able to hear the sound. So this is about the cochlear part. Now the assessment of vestibular component. Vestibular component is mainly for the equilibrium, coordination. So whenever the child is having dysfunction of the vestibular component, child will have the vertigo, nystagmus. Then we have to perform some test. Fukuda stepping test, Romberg test, Caloric test, Oculocephalic test. In this video, you can see the child is having the nystagmus. So whenever vestibular nerve dysfunction is there, child will have the nystagmus, in which the fast component is directed away from the affected nerve. If the child is having vertigo, then we will perform the Fukuda stepping test. We will tell the child to stand and extend both the arm, close the eyes. Then we will tell the child to walk in place for 50 steps. So in this video you can see, if the child is having normal vestibular, then child will walk with no rotation on either side. If the child is having vestibular nerve dysfunction, then child will walk with more than 45-degree rotation to the affected side. Then we have to perform the Romberg test, in which we will tell the child to stand with the arm extended and make sure child should not fall. So the examiner should stand behind the child in a manner that child should not fall without touching the child. And then we will observe the balance of a child for full 1 minute. Then we will tell the child to close the eyes. Then again observe that child is maintaining the balance or child is swaying to the one side. Loss of balance is labeled as a positive Romberg test, and when the child is losing the balance even when eyes are open, that means child is having the vestibular dysfunction on the side of the fall. If the child is maintaining the balance with eyes open but lost the balance with eyes closed only, that means child is having posterior column defect, spinal disorder. Then we have to perform the tandem walk test, in which we will tell the child to walk in one line. If the child will have the vestibular dysfunction, then child will sway toward the affected side. Then we can perform the Caloric test. Practically in exam, we don't perform this test. Please, you should remember how to perform this test. In this, first we will check the integrity of the tympanic membrane. If it is intact, unobstructed, then we will elevate the head of the patient up to the 30 degree. With the help of the syringe, we will take the 2 ml of the cold water, 3 degree centigrade temperature, and similarly also with the warm water, 44 degree centigrade temperature, we will instill into the external auditory canal for the Caloric test. If the child is having normal brain stem function, then eye will be deviated toward the irrigation side, and also child will have the nystagmus, and the fast component of the nystagmus will be opposite side with the cold water, and similarly we have to perform with the warm water of the 44 degree centigrade, and the child will have the fast component of the nystagmus toward the same side. And we have to perform the Oculocephalic test or the doll's eye phenomena. Child should be in lying down position, and we will turn the head toward the one side suddenly, and the conjugate deviation of the eyes toward the opposite side occur if the child is having normal brain stem functions. Then 9th cranial nerve, glossopharyngeal nerve. As its name suggests that it supplies the tongue and the pharynx. So the function of the 9th cranial nerve, sensory function, it supplies the posterior 1/3 of the tongue, pharynx, tonsil, internal surface of the tympanic membrane, skin of the external ear. Also taste sensation to the posterior 1/3 of the tongue. And its motor function, it supplies the stylopharyngeus muscle. As the most of the function of the 9th cranial nerve are shared by the 10th vagus nerve, so in exam we have to simultaneously assess the both 9th and 10th cranial nerve. For 9th cranial nerve, we have to check the taste sensation over the posterior 1/3 of the tongue. Then we have to check the swallowing difficulty is there or not. Then we will perform the gag reflex. In this, we have to touch the pharynx or palate by the tongue blade, and when we are touching the lateral oropharyngeal region, we label as a pharyngeal reflex. When we are touching the soft palate or uvula, we will label as a palatal reflex. Afferent for the gag reflex is 9th cranial nerve, and efferent are both 9th and 10th cranial nerve. In response to this, there will be elevation of the soft palate and uvula occur, and constriction of the oropharynx occur, and also the closure of glottis occur to protect the airway. So these three mechanisms occur together when we perform the gag reflex. Now if the ninth cranial nerve palsy is there, if the child is having unilateral supranuclear lesion, then there will be no deficit because of the bilateral corticobulbar innervation. If the child is having bilateral supranuclear lesion, then hyperactive gag reflex will be there, as seen in the pseudobulbar palsy or amyotrophic lateral sclerosis. If unilateral nuclear or infranuclear lesion is there, then the child will have the unilateral pharyngeal weakness and palatal raphe will be deviated toward the normal side. It is generally seen whenever child is having the intramedullary or extramedullary mass or having trauma or motor neuron disease or GBS. In this case, patient will have the difficulty in swallowing. Now the 10th cranial nerve, vagus nerve. It is the longest cranial nerve. There are 10 term branches of the vagus nerve: meningeal branch, auricular branch, carotid, cardiac branch, pulmonary branch, superior laryngeal, recurrent laryngeal, pharyngeal branch, esophageal branch, and gastrointestinal branch. Now the function of the 10th cranial nerve. Its motor function by its pharyngeal, superior and recurrent laryngeal nerve. It supply all the striated muscle of the soft palate, pharynx and larynx except stylopharyngeus, which is supplied by the 9th cranial nerve, and tensor veli palatine, which is supplied by 5th cranial nerve. And by its superior laryngeal nerve, there are again two branches of superior laryngeal nerve, internal branch and external branch. Internal branch is sensory, while the external branch supply the cricothyroid, while all other intrinsic laryngeal muscles are supplied by the recurrent laryngeal. Then the sensory function of the 10th cranial nerve. It supply the sensation of the pain, temperature, touch to the pharynx, larynx, ear canal, external surface of the tympanic membrane and meninges of the posterior fossa. Now for the examination of the 10th cranial nerve, we will perform the gag reflex as I have explained in the 9th cranial nerve examination. Also we will assess child is able to swallow or not. Then we will tell the child to open the mouth and say the ah. Then observe the elevation of the soft palate bilaterally present or not. Then also check the phonation, character of the voice. The child is having unilateral 10th cranial nerve palsy. Then the child will have dysphagia more for liquid than solid. Also child will have the nasal regurgitation because of velopharyngeal insufficiency. When you will check the phonation, you will find that the child is having nasal quality, hoarseness of voice will be there. Also because of the weakness of the ipsilateral soft palate, there will be drooping of the palate or flattening of the palatal arc occur, and the uvula will be deviated toward the normal side during the phonation and when you will tell the child to say ah. Also tachycardia, loss of oculocardiac reflex can be there. When the child is having bilateral 10th cranial nerve palsy, then it is incompatible with life because child will have the respiratory distress. There will be marked dysphagia, nasal regurgitation, pulling of the secretion occur. Palate cannot elevate on the phonation. Absent gag reflex will be there. Impaired cup reflex will be there. Child will have the complete paralysis of the pharynx and larynx. Also tachycardia will be there. GI atonia, vomiting and respiration can be slow, irregular. In vasovagal attack, because of the stimulation of the vagal nerve, because of its parasympathetic action, it will lead to the bradycardia, hypotension, faintness or unconsciousness can occur, bronchoconstriction, bronchoria, and increased GI peristalsis, increased GI secretions, and it will inhibit the adrenal function. Now the 11th cranial nerve, spinal accessory nerve. There are two parts of the spinal accessory nerve, spinal nerve and the accessory nerve. Spinal nerve is the major part of the 11th cranial nerve. It arises from the ventral horn of the C2 to C6. It supplies the sternocleidomastoid muscle and the trapezius muscle. While the accessory nerve, the cranial portion, also known as ramus internus, it arises from the caudal nucleus ambiguous. It emerges from the medulla laterally and it supplies motor fiber to the larynx with the vagus nerve. We cannot directly assess the function of the accessory portion of the 11th cranial nerve because it supplies the larynx with vagus nerve. So we have to assess the function of the accessory portion with vagus nerve only. Now for the spinal portion, we have to assess the function of sternocleidomastoid and the trapezius muscle. Sternocleidomastoid muscle helps to turn the face to the opposite side, and when both the sternocleidomastoid muscle contract right and left, then flex the neck and bring the head forward and the down. While the trapezius muscle help in elevating, retracting and rotating the scapula. Also, it will help in abduction of the arm above the horizontal position. For the examination of the spinal portion of the 11th cranial nerve, we have to assess the function of sternocleidomastoid and the trapezius muscle. For the sternocleidomastoid muscle, we will tell the patient to turn the head to one side, and also we have to assess against the resistance by keeping our hand on the child face. At the same time, we will observe the contour of the sternocleidomastoid muscle. Also, we will palpate. If the child will contract the left-sided sternocleidomastoid muscle, face will be turned to the right side. And for the assessment of both right and left sternocleidomastoid muscle, tell the patient to flex the neck. For against resistance, we will keep our hand over the forehead or over the chin. Now for the assessment of the trapezius muscle function, tell the patient to shrug the shoulder. For against resistance, we will keep our hand over the shoulder and we will again tell the patient to elevate the shoulders. Then we will tell the patient to approximate the occiput to acromion. Also observe the contour of the trapezius, scapular position, any asymmetry is there or not. Now if the child is having 11th cranial nerve palsy, due to the weakness of sternocleidomastoid muscle, child will not be able to flex the neck and also will not be able to turn the face opposite side. And due to the weakness of trapezius muscle, there will be drooping of the shoulder occur and flattening of the trapezius ridge occur. Now the 12th cranial nerve, hypoglossal nerve. It supplies the muscle of the tongue, and the function of the 12th cranial nerve is it will help in protruding the tongue, retracting and elevating the tongue. So for the assessment of the 12th cranial nerve, tell the patient to open the mouth, then observe the contour and the bulk of the tongue. Observe any atrophy or fasciculation is there or not. Then tell the child to protrude the tongue, move it in and out and from side to side. If child is able to move the tongue freely, that means it is normal. Now if the child is having the 12th cranial nerve palsy, in unilateral, tongue will be deviated toward the paralyzed side, while in the bilateral, child will not be able to protrude the tongue, and in infranuclear and nuclear lesion, child will have the atrophy and the fasciculation of the tongue also. So this is all about the 8th to 12th cranial nerve. In next video, I will tell you the details of motor system examination. Thank you so much.